In part 1, I talked about the first 4 of 8 important principles of trauma-informed care. To quickly review, they are client safety, trustworthiness and transparency, prioritizing client autonomy, which means the client's ability to make decisions for themselves, and cultural sensitivity. Today, I'm going to cover the other 4 principles. Avoiding re-traumatization. Another aspect of safety in trauma-informed therapy is making efforts to avoid a client becoming re-traumatized as a result of therapy. This can happen, for instance, when a client is treated under the old paradigm of needing to tell the story of their trauma and re-experience all the horrors and emotions again. In my practice, I try to keep talk about the specific trauma at a very high level, what I call the 30,000-foot flyover level. I might ask, if your trauma was a book, what would the title be? And that's as specific as I'd want to get initially. My intake paperwork lists various types of trauma and asks clients to mark any they've experienced, but I do not ask for any details. I also tell clients that if anything in my intake paperwork is triggering for them, they should skip it or just write "not now." This is all part of my effort to avoid re-traumatizing my clients. Many trauma clients will overshare, and this is even more likely for clients who have seen many therapists searching for help. They feel like they need to open their trauma bag and dump it all out for me to see at the start. I do my best to prevent clients from doing this because they have no trust in me at this point, and there is, at most, a limited sense of safety. They have no idea if I'm going to judge them. And quite honestly, a lot of times when a client is allowed to overshare early on, it feels really awful, and they don't want to go back to that therapist. I want my clients to be able to share only the necessary details of their trauma histories when they are ready and feel safe. And the processing of traumas should only occur once the client has the skills to handle the big emotions and the sensations that processing is likely to bring up. Principle 6, knowledge of common trauma outcomes. Signs of trauma can be easy to miss. Trauma-informed therapy requires the therapist to understand those signs. For instance, dissociation is a very common outcome of trauma, and not only is it frequently missed by therapists, they don't even know what signs to look for. Hypervigilance is another common outcome, and its opposite, hypoarousal, which is often misdiagnosed as depression. And this matters because if dissociation goes unnoticed, it can't be addressed. And if a client is misdiagnosed as having depression, they receive a treatment that does not address the actual root cause of the symptoms. A lack of understanding of trauma is why many professionals still don't believe that DID is real, even though it's in the DSM. A lack of understanding of trauma is why so many people are diagnosed as having borderline personality disorder, or bipolar disorder, or schizophrenia, when it's DID or OSDD. The 7th principle is coordination of care. Ideally, your therapy should be coordinated with the other medical care you're receiving. In reality, however, it can be challenging to get time with your doctors and psychiatrists to do this. They don't make talking to me a priority. And lastly, the principle of therapist self-care. Your therapist should be taking care of themselves so that they are able to continue to be there for you. Trauma therapists are at risk of what is called secondary or vicarious trauma. This means listening to details of horrible traumas, empathizing with clients, and seeing the impacts of those traumas on their clients can begin to affect therapists. It can cause therapists secondhand trauma. They have an obligation to take care of themselves so they can be present with you as you work through your issues. You can see how these 8 principles work together and support each other and the client. One thing not specifically mentioned that is also important in trauma therapy is dealing with shame. Trauma survivors typically have lots of shame pertaining to their trauma. In the case of DID and OSDD, shame may be from things you were made to do by your abuser, or from the thousands of times you were told and made to feel that you were worthless. Shame is easy to trigger, and while it's likely to still happen even in trauma-informed therapy, the practices of trauma-informed therapy will reduce the frequency of shame and position you and your therapist to deal with the shame more effectively. Now, I've put together a list of questions you can ask your potential therapist to find out for yourself if they seem to provide trauma-informed care. To get a copy, go to this link. I would be very interested to hear the comments in the comments examples of trauma-informed therapy that you've experienced and why it was so helpful to you. By sharing, you can help others see what they should expect.